You're listening to the Primary Care PT podcast. I'm your host, Dr. Katie Obright, and we're going to talk all things primary care PT. Stay tuned and subscribe. Okay, hi everybody. This is Dr. Katie Obright. I'm back with the Primary Care PT podcast. This is a part 2 episode with Dr. Barney, which we heard from a couple of weeks ago. And today we're going to segue and sort of talk a little bit more about something that is close to his heart, no pun intended. And literally, I actually did not mean to throw the pun in there, but cardiovascular health for athletes, for people that we don't necessarily think might be at risk for cardiovascular issues. I have some interesting features that I pulled up. I think one of the reasons why I'm most interested in this topic, I'm not most interested, but interested in general, is because I am a huge Buffalo Bills fan. Everybody knows that who follows me. And for those who follow the NFL and saw what happened in early January of this year, 2023, to Damar Hamlin, he had that hit that everybody was like, wasn't even that big of a hit, but it was just at the right time where he had a near-death experience and had to receive CPR on the fields by an athletic trainer. And so that sort of spun off this whole trend kind of people talk, physical therapists, athletic trainers, cardiologists, other people in the healthcare community talking about the cardiovascular risk and cardiovascular events that can take place in our athletic population and why we should be paying attention to it. So Brian, tell us a little bit about you and you, for those who listened to the previous episode, know a little bit about your running background. And you also had a cardiovascular event at a young age. So tell us a little bit about that.
Yeah. So, like you mentioned, I have been running for a while. Started running when I was 10. I'm 30 now, so been doing that for 20 years, but always been involved in sports from a young age. Um, what I found out in 2019 through a series of events was that I had a congenital heart abnormality. Of course, I had it since birth. I just didn't find it out until I was 26. So, what happened was, I'll give you the short version of it. I was out running one day and actually crossed paths with the director of my PT program. Now, at this point, I graduated maybe a couple months prior to that, maybe half a year prior to that. And so we crossed paths. I stopped to talk to him. In the middle of me talking to him, I felt like, I don't know, really woozy in a way that I never had before. And the next thing I know, he was, shaking me, trying to get me to wake up. And I was on the ground in the middle of the street, wondering what happened. It was like I woke up from going to sleep. So I, passed out or had syncope. I think is the term for it. So that was the first time that happened. A week and a half later, I was at one of my fraternity brothers' weddings, and we have like this stroll thing that we do that involves a lot of jumping around, so get your heart rate up pretty quickly. And so then after that, I was in a circle talking to some of them, saying got the same feeling, and it was one of those ones where I felt myself waking up, and then of course all the guys are staring at me because they're like, "What happened? You just passed out." I was like, "Okay, well, happened again." So um, from there, I decided I should probably go see a doctor about this because I was just the first time it happened, I was just thinking, well, my blood pressure dropped, or typical man stuff. Just try to shake it off.
Minimize.
Um, yeah, minimize. Yeah, minimize it. But after the second
An
time,
expert at that, by the way.
after the second time, I was like, all right, I should probably go see somebody about this. So I did, got in to see an EP doctor, electrophysiologic doctor. I think that's what that stands for. And they started doing testing. And at first, they really weren't finding much with the typical test. So I did an echocardiogram, which I learned later that an adult echocardiogram and a pediatric one are different because in the pediatric one, of course, they're looking for these congenital abnormalities, when the adult one, I guess they aren't. Um, so did that, had got the EKG that was relatively normal. Then I had a stress test where I was, running on a treadmill for 20 minutes. That even was fairly normal. Then I got a cardiac MRI. Um, Actually got two cardiac MRIs because the first time they forgot to give me the dye. So
Oh my
then
gosh.
that's when then with that they're like, we think that we see something. So then I got a cardiac angiogram, and that's when they saw that I had an anomalous right coronary artery, which essentially means that my right coronary artery starts right next to my left one, which in a typical human heart, that's not how it's supposed to go, because then the right coronary artery has to travel an abnormal route, and it can change the shape of the vessel, which it did for mine, and then the vessel can end up getting compressed by the heart wall, with each time your heart beats. And of course, that would become worse as you exercise because your heart's beating harder and
Right.
faster. And
Mhm.
so that probably led to the arrhythmia, which led to me passing out. Thankfully, it was just passing out and not cardiac arrest, because that is what happens sometimes. And the specialty doctor that I went to see said that another person who had the same condition as me did have that happen. So they were just running on a treadmill and then just went to cardiac arrest. And thankfully, there was a medical resident nearby also running on the treadmill at that particular time, and was able to give them CPR, and the person was able to get the issue fixed. But that's essentially how I found out what was going on with me.
That's terrifying. But so you brought up a couple of things that I thought were interesting, but also common. So the first time that it happened, actually both times that you had these episodes, was anybody or were you concerned enough to maybe go to the emergency department?
No. Funny. So the first time I got back up, my professor he walked with me a little bit, and then I just walked the rest of the way back home. And then I went in to work, and so I had a bandage on my arm because, fell, hit my arm, and scraped it up some. So then they were asking me, when I got to work, it's like, what happened? Like, you're bleeding through your bandage. And I was like, oh, well, kind of passed out. I was running this morning. They're like, all right, that's weird. But we just kind of, went on with the workday. And then the
Uh-huh.
second time, um, so at the time we were living in Kentucky, and the wedding was in Cincinnati. So we were going to drive back to Kentucky that night after the wedding, my wife and I. Um, Even after I passed out, that was still going to be my plan. But then somebody talked me out of that. It's like, how about you just come stay at my house, or find somebody's house to stay at, or I'll buy you a hotel, something. Like, you should probably not drive home right now, which was a wise decision in retrospect.
Hmm.
So no, no. To answer your question, no, no, I did not think about going to the emergency
So
department.
now, okay, so now in hindsight, let's say you had a patient where this took place, now knowing the things that you know now about these events. In hindsight, might you have done anything differently?
Oh,
I'm
for sure, yeah, I definitely would. You know, here's the thing: they should probably be sent to the ED, or at least get some sort of further workup. I mean, I skipped a couple steps in that just because I happened to go to church with a doctor who worked in office with an EP doc. So I skipped the go to, because I didn't have I mean, I was 25 years old. I didn't have a primary care.
mm-hmm.
So I had to go to primary care, and then I have to get a referral, and then I have to go to the EP doctor, where this guy was like, well, I can find a way to get you into see the EP doc this week.
There you go.
So in some ways, like, yes, yeah, you should go to ED. You should get it checked out, make sure that they can take a look at things. But they probably did the same tests
Yeah.
that I got initially, which didn't tell me anything.
Hmm.
So it's
Okay,
kind
so
of
here's my take on this. In those acute episodes, or if you're made aware of an acute episode like that, a syncopal episode in an athlete of unknown origin, especially where you kind of wake up and you feel pretty tired, pretty fatigued. In those acute episodes, the one different thing that they could do, or maybe should do in the ED, which I'm
hmm
not an ED physician, and I know there are problems in EDs, but the one different thing that they could do is potentially look at your cardiac markers. looking to see if there's any breakdown going on, if you are in
Mhm.
some sort of cardiac arrest, if that took place. The further the window gets from that acute event, my understanding is, which I'm not a cardiovascular and pulmonary specialist, but my understanding is the further you get away from that acute event, especially when you are an athlete, the more or the less likely it is that they might identify something. So in my experience, I've been experiencing like cardiac chest palpitations for a long time. A lot of times for me, it's stress induced, meaning like mental stress induced. But I also get it when I'm exercising, where I get these sort of palpitations, feels like it's fluttering outside of my chest. And recently, I had another episode, and I'm really going to be telling on myself because I'm a minimizer too. I think we all are. It's bad. But we were at a Cubs game. It was the first time taking my boys to the Cubs game. This was after the course where I met you. And the I don't even know who the player was, but hit a homer and it was so exciting. I just shot up and started cheering. And I almost instantaneously felt complete flush. Like I was looking
Mhm.
at something and I was picturing myself like my head crashing into the stairs. But I like both arms, like complete numbness.
Mhm.
I just felt like the blood just drop to my feet. And
Yeah.
luckily, like my husband was standing next to me, like kind of stabilized me, and I just sat back down and I was like, I have no idea what just happened. I felt like I was going to pass out. But within, 10, 15 minutes, it was better, but I just sort of felt tired the rest of the day. And this is not like what I just described to you. I have like kind of a known history of this. So I wasn't like terribly concerned or thinking I was going to die or anything, but it was scary because I really thought I was going to pass out. And I know that when I exercise more intensely, like when I'm biking and I'm on a climb, a really intense climb, like I do kind of get these sensations. And so I think that there's this overarching understanding or like just assumption amongst healthcare professionals and amongst the general population that if you are quite fit and if you are, if you're an elite level athlete, you're you're good. Like especially heart health, we know exercise is really good
Mhm.
for you, blah blah blah. But I honestly think that, and now that the studies, some of the studies that I have looked at have demonstrated that people who are elite level athletes for a longer period of time, and I'm talking elite level, this is like the studies I was looking at were primarily looking at NFL players, Iron woman, man,
Mhm.
runners or
Mhm.
professionals, that they generally have a higher prevalence of cardiac arrhythmias. So I'm wondering what you think. So okay, I'm getting ahead of myself. Before we get to what's important for physical therapists to understand about screening for this, let's
Mhm.
go back to what happened in your case with your anatomic anomaly.
Yeah, so what happened was, eventually after all the testing, I got referred to an adult congenital heart specialist, which there are not very many of those because most congenital heart conditions uh, get fixed when you're a child, typically. So I went and talked to him, and the doctor I was seeing previously, who referred me to him, told me, surgery might be on the table here to fix this issue. So you know, I wasn't shocked when he said, I think with your two events that you've had, you want to be physically active and do it safely. I think you should get surgery. So for me, in my mind, I knew pretty immediately. I'm like, okay, well, you can't operate on my heart with it still beating. It's not one of those ones where they go put in a stent, and go
Right,
to your femoral artery. Like
right.
you're gonna have to. This is gonna be open heart surgery. So I was like, okay, well, guess that's what we're doing. So
My
I had
gosh.
open heart surgery December 17th of 2019. Um, it was a week before Christmas. My daughter was 3 months old, so my wife was pretty
Freaking
scared.
out.
Yeah,
I would have been losing my mind.
yeah. So anyways, yeah. So I had the surgery, and had a obviously a recovery period after that where I couldn't do certain things. I had to ease my way back into certain things, and then I just kind of I use running as like my uh, cardiac rehab. Just bought a nice heart rate strap, heart rate monitor, and use running as my rehab, and kind of just got back into all the stuff I was doing before. Since then, without really any issues, other than just kind of being more aware of how I feel, and now that I coach high school athletes, being always scouting out where the AED is around, or
Yes.
where all the AEDs are.
Yes.
So in case something like that were to happen to somebody else. So.
Hmm. Yeah. So I'm glad that you just brought that up because, well, first of all, like, so glad that you're doing better now. So glad that you didn't end up one of those cases that was a cardiac arrest because
Mhm.
I'm sure that many of us and people listening to this podcast have heard of individuals that have sudden cardiac death before the age of
Mhm.
50.
Mhm.
I'm aware of at least 3 cases where that happened in people who were under the age of 50, generally males who are young, like fit, out running or rowing or biking or doing something, where they suddenly, pass out and have a cardiac event, and some of them do not survive. And it's
Mhm.
terrifying. And it's always unanticipated. So some of the things that we can look for, or some of the things I just want to bring up. So amongst NFL athletes, and I'm actually just going to pull up this, it was, hang on one second, let me pull it up here. It was an abstract, so just like a presentation at the
Mhm.
American College of Cardiology scientific session in 2018. They were looking at the pro football players that are susceptible to arrhythmias. And for whatever reason, this population, and they also mentioned others, so long-term endurance athletes. So like, your Tour de France bikers and your Ironman athletes, Iron Woman athletes, that they, for some reason, compared to a normal typical population, have a much higher percentage or much higher risk of developing a cardiac arrhythmia. So we all saw this last year with Damar Hamlin. I think I mentioned this. Did I mention this early in this episode or the last episode? I don't remember. But so Damar Hamlin, that actually was not a case of arrhythmia, but it was a really rare instance of commotio
Mhm.
where a sudden impact to the chest at just the right time in the cardiac cycle causes the heart to basically stop beating. And luckily, Damar Hamlin actually is back. We're in July of 2023 right now. Damar he's back to training, and the last I heard, maybe expected to play this upcoming season. So hopefully, and it seems like he's doing well, being followed by his medical providers. But we also saw last season, JJ Watt of the Arizona Cardinals, he's a defensive end, also developed a cardiac arrhythmia where he had to
Mhm.
be cardioverted. And we also saw this in Caleb McGarry, who now plays for the Falcons, had a cardiac arrhythmia before he went into the NFL and had
Mhm.
to get that managed before playing. So these are not super uncommon. I think that they're just under recognized. And some of the signs and symptoms are really consistent with some of the stuff that you've mentioned. That feeling of like dizziness, lightheadedness, the feeling of like just being really, really tired, overly fatigued, certainly
Mhm.
syncope, heart palpitations. But in my case and in some of the other cardiac cases that I've seen, they kind of almost present like what you would think of as like a nerve issue, like a peripheral neuropathy or like a cervical radiculopathy, where you get one or both arms that have numbness, tingling, a feeling of heaviness, which is exactly what I experienced at the Cubs game. And I 100% think it was cardiac related. So I'm curious what you think about with now knowing these things and knowing that the risk of atrial fibrillation amongst higher elite level athletes, whether they're in the middle of their professional career, professional sporting career, or down the line, developing more of these things. What do you think is important for physical therapists to know in the screening process of like patients with arm symptoms or
Mhm.
other types of symptoms? Like, what do you think would be important for like differential diagnosis whenever somebody comes in with like, oh, I had this arm pain and I am also an endurance biker or whatever, cyclist.
Yeah, yeah. I think certainly you would want any good physical therapist would ask, okay, well, when do your symptoms start? When do they stop? How long do they last?
Hmm.
Right? If it's only with the things that get your heart rate up pretty high, that will be a sign. I think something that I've started doing since taking your course is just taking people's pulses at their wrist, and then if
Okay, so
something
manual
seems
pulse. Hmm.
yeah, taking a manual pulse, yeah, and if something seems off, I'll get my stethoscope out and listen to it some more, and then going in and informing the person about that, but also informing people's doctors about it. Thinking back to my own case, at one point in time, I'm pretty sure a doctor told me that I had a heart murmur, but it's one of those things where you think maybe it's just going to go away with time,
Hmm.
that as you grow up. Um, but in retrospect, if I would have, if maybe we would have investigated that a little bit more, I could have found this a lot earlier. So, for example, my son, we took him to the pediatrician, and he said, okay, he has a bit of a heart murmur. So we took him over, knowing what we know about me now. We took him
Your
over
history,
to Cincinnati Children's and had them take a look at it. And they did an echocardiogram that day and checked everything out, and everything looked good. So now we don't have to worry about that anymore. And we figured it out with him when he was probably less than a year old. When for me, I didn't figure that out until I was 26.
yeah.
So, um, another thing I talked with, so I had my surgery done at the University of Kentucky. And when I went back for a follow up, I was talking with uh, the tech who was doing a follow up, echocardiogram, and she was saying how for all of their student athletes, I'm pretty sure they do a pediatric echocardiogram, and I think maybe an EKG as well, which I think is great. Obviously, those tests are very expensive, so that's a challenge for people to get them, or even just an institution to provide that for athletes. But I do think about my high school athletes I coach sometimes, where they're kind of just out there running. I'm like, do we really know what's going on with their hearts? I mean, I hope nothing bad happens. So on my end, just knowing what I know in my personal experience, I always run with my phone now. I try to make sure we always make sure nobody gets left behind, but really want to double back and make sure nothing bad has happened to anybody.
Mhm.
So those I think are some of the things, like the way I think about it as a PT now who has had this experience of really just paying close attention to people's symptoms, and asking more follow up questions.
Hmm. Yeah, no, I think that's great. And I think so we would all love, and I actually had a patient recently ask me like who they identified something in a non-routine colonoscopy. It was for something symptom related. Um, like aren't there like full body MRIs or like CT scans that we can get to like identify things? And I was like, you know what? That probably isn't worth it because of the cost and because of the number of like incidental findings that have nothing to do with your risk for X, Y, or Z. So doing something like that is probably not all that worth it. Just like you were mentioning, like it's not feasible nor necessary for every child to like get a pediatric echo. However, we know in the research, like high school sports actually have the highest prevalence of these types of cardiac episodes in high school athletics because number one, you that's when in terms of the lifespan and hormones and when your athletic potential is really being tested and your body's kind of beginning to be at an adult level, that's when these cardiac episodes tend to come out. So my guidance to anybody out there, especially if you have a teenager who's
Mhm.
playing sports, or if you are a coach, or if you are an attending provider who's taking care of a team, always making sure you know where that AED is during a practice, during a game. I would, if you are, especially if you're one of the providers that is that's with them, if you don't know where it is, or maybe if you're practicing or playing a game in a remote location, having one with you to
Hmm.
just take to have on standby, because AEDs can be exceptionally life-saving in these events, and in high school athletics in particular. These events happen more commonly than they do in college and elite, because in college and elite, especially Division I college, they spend more money on screening their athletes
Hmm.
for the variety of health conditions that can come up, whereas in high school they don't. So is it necessary to do these things in everybody? Probably not, but it is important to maybe educate your athletes on, okay, um, we don't want to push to the point of passing out, because in certain cases passing out can actually be indicative of a cardiac problem. So maybe, just changing up like the culture of defining intensity or defining toughness, which, being an Army veteran, I think that that's coming along, hopefully. But um so that would be like my first thing. Definitely knowing, being adequately trained in CPR, knowing how to use the AED, and also knowing the location of the AED at all times. But then educating your athletes on signs and symptoms to look for if and when you're running. If you start to feel faint, you start to, start seeing spots, kind of start feeling that flush, like the blood rushing to your feet, it's time to stop and like look at, is it cardiac, or is it maybe overtraining? Is it a nutrient deficiency? Is it dehydration? There's
Hmm.
so many different contextual factors that play into all of these things. Also, like performance enhancing drugs, energy drinks, not enough sleep, too much
Hmm.
mental emotional stress. All of these things actually have a really profound effect on the cardiac system, and can lead to, or be, they can precede potential arrhythmias coming on. So tell us a little bit just about like how you educate your high school athletes that you work with.
Yeah. So it's cross country training in the summer right now. So obviously, us running out in the heat, and granted, we run at 8 a.m. in the morning to beat the heat a little bit. But we'll mention things to them specifically in regards to hydration. And a lot of times it's the head coach, and I'll just tag along on what he's saying. But it's like, okay, well, if you are out there running and you're sweating and you stop sweating, it's not a good sign, right? If you're running and you're feeling hot and then suddenly you feel cold, also, not a good sign.
Mhm.
I think most of the athletes at this point know that I'm a PT, so they'll go to any of the coaches, but specifically they'll come to me if they're having some sort of pain or whatever's going on, and I'll just ask a couple of quick questions to make sure nothing's seriously wrong, and then try to get them moving in the right direction, whether that's they stop running for today, or they take a break, or we alter the workout, whatever it is. But certainly, I've definitely am looking, especially during workouts where I'm not running along with them. I'm looking at people's faces. I'm looking at their body language to see, okay, how are they managing this? Are they just working hard and having a normal response to exercise, or are they like not looking good and I need to pull them off? So that's a lot of the conversations that we have with people is making sure that when they're out there running, they're having a normal response to exercise and knowing what that feels like, as opposed to other things that can be threatening to their health.
Yeah, I think that's a really good perspective. All, coaches or people who work with athletes on a regular basis, getting to know what their norm is like, because there are certain people that look just cool as a cucumber all the time. And then there are certain people who are really intense, and maybe their emotions fluctuate and their facial expressions fluctuate. But just getting to know what their norm is so that you can identify something that is um, out of the norm for them. I think that's really super important. The only other thing that I wanted to bring up, especially when it comes to cardiac testing. So if you think that you have, younger athlete that is, exercising at a pretty good intensity at a regular basis, whether it's elite level or whether it's even just recreational or just something they like to do for fun. Sometimes if you go in and you do these cardiac tests, just like I mentioned before, and like you mentioned, a lot of them might come up quote unquote negative. And it could be that maybe there's not the correct stuff being done. And that's not to discredit anybody who sees you the first time, but there's
Mhm.
there's so many different layers to cardiac dysrhythmias that take place in athletes. One being nutrition. So looking at a blood panel to see like what are their calcium, magnesium levels looking like, potassium, and hydration. Certainly all of those
Mhm.
things can be a factor. Drug related or energy drink related is that a potential contribution? But also like for me, I know when I first started having these like flutter and palpitation episodes, I got an echo. I've actually had multiple echoes because just like you, when I was doing my flight physical to get into the Army, because I was as a backup plan, if I didn't get into PT school, my number one was aviation. So I was doing my flight physical. She heard a heart murmur. So I got the echo. Echo was normal. EKG or ECG was normal. So I was good to go. Check that box. But then I started to develop things over time. And so I got, another echo. Again, things look normal. I got a stress test. Now, the stress test that I did not push to my max. And like, because they had me do this walking test on a graded like incline. It's a
Mhm.
protocolized stress test.
Yeah.
But it's a
Hmm.
protocolized stress test for people that are not fit. And I just remember thinking and
Hmm.
looking at the tech being like, oh, they were like, oh, well, you're done with the test. And I was like, I'm probably like RPE scale wise, rate of perceived exertion. I probably was at a 12. And I was just like, nothing's happening. I'm not getting symptomatic, but I'm also not anywhere even close to like the maximum intensity that I could give. And so I was like, so is this the test? Like, is that what you're using? And then in talking to like other cardiologists in the future, like you kind of have to get close to like where you're symptomatic in order for something to come out. So I think that it's important for people to understand that concept because just because you have one negative test after the other, get in good connection with a good cardiologist who really knows like what they're doing and what the whole comprehensive picture looks like to make sure that that patient truly does not have something cardiac going on. Um,
Yeah. Yeah. So similar to you, I did a stress test. Now, I happened to, when I did mine, I happened to look at, their screen with, the medical information on it. And basically the doctor's instructions were make him run until he passes out. So I did kind of push it pretty hard, but I was running for, I don't know, probably, well, I started off walking, right? And then they keep increasing the incline. So I think at the end I was running at, I don't know, 6 miles an hour, like 17% grade or something crazy like that.
Whoa.
It was like, all right, I'm done. Even if I wasn't like completely tired, I'm like, I think that I think
Yeah,
I'm at my
running at a
max heart rate now.
17% grade is like, I would probably just tap out.
Yeah. So and the thing is, both times when I had, my cardiac events, like one of them when I was running, I wasn't running. I was just doing a regular everyday run. Like I wasn't out running at my max. I
Hmm.
was just doing my regular run and then it just happened. So it's kind of, I don't know what exact sequence of events would, bring it on, but obviously if it could randomly happen, that's still a problem.
Yeah.
So, so yeah, those test, yeah, it can be a little tricky sometimes. Thankfully, since mine was an anatomical issue, there are ways that you can pretty much look at the anatomy of the heart. So that's how they were able to find it for me. But
Hmm.
in other situations where, like you said, if nutrition's part of it, if they're not getting enough sleep is part of it, that can be a little bit. trickier to diagnose.
Yeah, for sure. I think that it's just important to look at it from a comprehensive, holistic perspective, all things considered, blood, hydration, diet, sleep. But then certainly you can get down into the nitty gritty with, pathophysiology and, primary, secondary, blocks and stuff like that. So, I
Mhm.
think it would be interesting to like have a follow-on conversation about this with a cardiologist. And I happen to know somebody who might be interested in tackling that because I think that a lot of the research on sudden cardiac death is like the testing, sometimes it just won't come out. It won't happen at that right time. And
Mhm.
um, it's one of those things that like we haven't quite cracked the code on being able to fully prevent it and understand
Mhm.
it. So
Mhm.
maybe we'll do a follow-on episode with my cardiologist friend and
That would be fun.
we can get any more additional information outside of the PT perspective. Um, but Brian, thank you so much for coming on and giving us a lot of your time to talk about these things. This is again the end of a part two series, or excuse me, a two-part series. How can people find you if they want to connect with you?
So you can find me on social media on Instagram and Twitter. I think it's the same handle. It's just at Brian Barney PT. So Brian with an I, Barney spelled like the purple dinosaur, and then PT at the end. And yeah, you can connect with me that way. Shoot me a DM if you want to learn more about my situation, or if you just want to, chat about anything.
Awesome. Sounds great. Thank you so much for coming on today. And this episode will probably come out sometime in September. So happy fall, everybody. Happy football season. Go Bills. And that's a wrap. Thanks for listening. If you love our show, go ahead and subscribe to stay tuned for future episodes. As a thank you to our listeners, we're happy to offer $50 off of our Primary Care PT Foundations course or our Musculoskeletal Imaging certification. Visit us at redefinehealthed.com and use code PCPTPodcast, all one word, all lowercase, on the checkout page to claim your discount. That's PCPTPodcast, all one word, all lowercase. Until the next episode, stay awesome, y'all.